My name is Sahar Bedrood. I am an ophthalmologist, a glaucoma and cataract specialist based out of Los Angeles. I'm in a practice called Advanced Vision Care, and we are located in Century City, California. I have been doing canaloplasty for a number of years now with a variety of different techniques. I'm a recent adopter of iTrack Advance, and basically that evolved from trying new technology. I believe in trying different things, trying different innovations, and seeing what works best in your own hands and in your patient population. When we think about glaucoma, there are a lot of different ways that you can treat the disease. Traditionally, we treat basically the pressure. But I think we can take it a step further and treat the outflow, the Schlemm's canal, the things that are theoretically collapsed in these patients. So in canaloplasty, the idea is to viscodilate or dilate that canal and kind of invigorate it to work again. Other types of MIGS devices will be a little bit more pinpoint. They don't have that kind of outflow as much. They bypass things. I use all kinds of different devices. It's not like I'm down to one, but I think that using different things allows you to identify what works best for our patients. One of the things that I noticed during both the intraoperative and postoperative parts of my kind of evolution with this technique is that intraoperatively, I noticed that immediately all the vessels around the limbus that are in charge of basically outflow were blanched, which implies that there's movement of something through them. And to be able to get that kind of movement and opening is not common, and you don't see it that often intraoperatively. Even when we have so many different MIGS devices, sometimes that just doesn't happen. So I noted that right away, and I noted almost every single case. And then postoperatively, in the patients that I saw that blanching, I saw really great IOP reductions and a really calm, clean eye afterwards. Standalone offers a different thing than the combo. In standalone, you're really trying to invigorate everything. And then I really actually like doing standalone procedures because it tells you if what you did by itself works. In combination with cataract surgery is always great because that way you can do the cataract. It's one procedure. Patient goes to the operating room one time, and we are able to kind of maximize the time that they're in and maximize the other operative risks that are there. So there's no right or wrong answer. I think it depends on the scenario for the patient. Patients who I am not going to be doing any cataract surgery for, so these are going to be younger patients, maybe patients a little bit earlier in their disease process for glaucoma, patients that I still want to continue having their other real estate for conjunctiva or keeping their angle intact. These are patients that I would do standalone in. And I have no interest in doing cataract surgery in those younger patients, so this is a perfect scenario in which I can do something as least invasive as possible. My patient population consists mostly anywhere from mild to severe glaucoma. Patients who are who've had some kind of therapy, either SLT or drops, are either not responding or are intolerant to the drops. Those are patients where I have to have a discussion that something more needs to be done. Continuing to add drops into a patient that is not responding or is intolerant doesn't really make sense. So I have to have that surgical discussion, and it is rather easy to discuss canaloplasty or angle surgery with them because it's considered less invasive, there's not a lot of downtime, there's not a ton of post-operative kind of complications or management that has to be discussed with the patient. So I think that it really should be amongst the first line surgical treatment for our patients. One of the things that I found most surprising is that there really was very little blood or blood reflux and hyphema after canaloplasty. And I think that was wonderfully surprising, but also it's a testament to how gentle the catheter and the guide wire is. I think the material is made such that it doesn't shred things along the way. I think that it expands the canal and all the collector channels along the way without having this kind of recollapse and reflux back. And I think it's really a testament to how easily that is all done and how minimally invasive it is. So I did not use the original iTrack, and some of the reasons for that was, it was a little more cumbersome, the experience. So I never started it. I think that changing the handpiece, making it more friendly for all surgeons, and being able to do this without as many cuts into the eye has been definitely a true advantage. And that's why I adopted it and tried to use it. I think that I've been really, really happy with that. iTrack Advance with canaloplasty surgical tips include, I think once the eye is formed, you need to make that paracentesis. So there's your regular para for if you're doing cataract surgery, and then another para. Aim that kind of towards that angle, getting the tip, when you get the injector in, getting the tip and just angling it upwards is really, really key. If you angle it down, it's going to want to go down into the ciliary body. So angling it upwards at maybe like a 35, 45 degree angle, and then advancing it, going really, really slowly, being patient, with both the advancement and also, most importantly, with the retraction, because every single time that you retract and you call out the number and there's a click, there is a push of viscoelastic into the collector channels and the Schlemm canal, and I want that to be seamless and not with very much reflux or not in a rush, basically. So those are some of the tips that I would include. I pressurize the eye afterwards, although there is little reflux heme that I see, but just to make sure.